Hello everyone, a very warm welcome to the part 2 video of thyroid carcinoma where we again go through the papillary thyroid carcinoma with the content like the variants of the papillary thyroid carcinoma, clinical features, diagnosis and treatment. So let's begin with the histologic variants of the papillary thyroid carcinoma. We can see three variants, that is tall cell variant and diffuse discoloration variant and follicular variant of papillary thyroid carcinoma. First, we go the pathogenesis. We see what gene mutation or molecular abnormalities can be appreciated in such variants of this PTC, and there is RET and PTC translocation, which we discussed in the part 1 video of thyroid carcinoma, and also there is a BRAF mutation that co-occur in tall cell variant, while in diffuse discoloration variant only RET PTC translocations are present, while in follicular variant that harbor distinct molecular abnormalities like RAS mutation, RAS gene mutation. Such things can be seen in follicular variant of papillary thyroid carcinoma, and this occur in older people, while this occur in younger people, and there is a high frequency of vascular invasion, and there is a prominent papillary architecture. And similarly, the nuclear features in follicular variant of papillary thyroid carcinoma are similar to PTC, but they have follicular architecture. And these tall cell variant have tall columnar cells with intensely eosinophilic cytoplasm, and also there is a higher frequency of extrathyroidal extension and cervical metastasis to distant sites, while in diffuse sclerosing variant, that papillary architecture has the nest of squamous metaplasia, and there will be prominent lymphocyte infiltration which mimic the Hashimoto thyroiditis. And also there is extensive and diffused fibrosis throughout the thyroid gland. And in case of follicular variant, if it is non-invasive one, then that has no capsular invasion, but in invasive one there is involvement, or there is capsular invasion, and also there is a low risk of reoccurrence or metastasis of non-invasive encapsulated follicular variant of PTC. These are the various features of the histologic variants of papillary thyroid carcinoma. Next, we move to the clinical feature of papillary thyroid carcinoma. Here we see there is mass in cervical lymph nodes. Only that happen after the involvement of the cervical and the regional lymph nodes. And these lymph nodes are freely movable, and there is a single nodules, and that is freely movable during swallowing. And in advanced stage, there is harshness or dysphagia or cough or dyspnea to the affected patient. And prognosis depends on age, presence of extrathyroidal extension to distant, and distant metastasis to distant site, and excellent prognosis with a 10-year survival rate in more than 95% cases can be seen, and also the outstanding prognosis on lobectomy, uh, that is papillary microadenomas and non-invasive follicular variants of papillary thyroid carcinoma has outstanding prognosis on lobectomy, and also there is a 10 to 15% metastasis to distant site, and 5 to 20% have local or regional reoccurrence. Now we go through the lab diagnosis of papillary thyroid carcinoma. First we see the imaging through the CT, MRI or nuclear scan that may be used to check for the spread of the cancer. And also fine needle aspiration biopsy can be done, where a thin needle can be used to collect the cells from the nodule, and the various microscopic features which we discussed in part 1 video of thyroid carcinoma, like papillary structures, nuclear enlargement, grooves, elongation, overlapping, pseudo inclusions, and ground glass, or clearing chromatin, or uh, you know uh, any eyes appearance. So such microscopic features of this papillary thyroid carcinoma can be appreciated with the help of the cell that has been aspirated from the nodule with the help of the thin needle in fine needle aspiration biopsy. And next we can do is molecular testing for the diagnosis, and that if this can be done only when this fine needle aspiration is indeterminate, that is unable to identify the or differentiate this papillary thyroid carcinoma. So genetic tests can be done to diagnose such things, and there may be order to look for specific mutation like the BRAF B600E mutation, which we discussed in part 1 video. And there is the treatment of papillary thyroid carcinoma, where we see the first primary treatment is surgery of the papillary thyroid cancer. First we see the thyroidectomy. First is lobectomy, or the partial thyroidectomy. There is the removal of one lobe, and typically this is done when there is a low risk papillary thyroid carcinoma, but if it has become so malignant, then total thyroidectomy is done, where the entire thyroid gland is removed, and this is must perform the thyroidectomy, and especially if this radioactive iodine therapy is planned. So in those cases, total thyroidectomy is done. And neck dissection. In the neck dissection, there is, if the lymph nodes in the neck show sign of cancer, or it thought to have spread there, then there is they may be removed during surgery. And next is radioactive iodine therapy, and this often used after the surgery, and this is done to eliminate any microscopic cancer cells that remain in the body. And there is radioactive iodine taken up by the thyroid cell destroys any remaining thyroid tissues or cancer that has spread to other parts of the body. And next is a thyroid hormone therapy. Here, after a total thyroidectomy, lifelong thyroid hormone replacement therapy is necessary uh, to replace the thyroid hormones. The because thyroid is completely excised from the site to treat this, and in that case thyroid hormone is not naturally synthesized inside the body, so synthetic thyroid hormone is replaced there. And targeted drug therapy, where for advanced or metastatic papillary thyroid cancer, tyrosine kinase inhibitors are used, and this target for a specific protein in the cancer cells, and this blocks a signal that promote the cancer cell growth. And other therapies could be like external beam radiation therapy, that may be used for cancers that do not respond to other treatments, or if cancer reoccurs. And ablation therapies, where heat or radio frequency ablation or cold or cryoablation can be used to destroy the cancer cells that have spread to other organs like liver, lungs, or bones. Such things can be done for the treatment of papillary thyroid carcinoma. Thank you for having patience.